the Black Doctors Podcast, Season 6.
Hello, welcome back to the Black Doctors Podcast. I am Steven, your host. Again, once a month, I want to take an episode and really just talk about medical ethics. It's something that I'm passionate about in addition to, my clinical training as an anesthesiologist. If you're watching the video, you'll see I'm kind of in a more relaxed setting. I'm actually home for Thanksgiving holiday and set up kind of a portable makeshift recording studio. So hopefully this sounds okay and I can do some magic in post-production to make sure that the quality remains the same. This week, I want to talk about within the realm of medical ethics, there is autonomy, there's informed consent. And I think one of the ways that it comes up very frequently in a major way is when managing and working with Jehovah's Witness patients that practice their faith.
This podcast is sponsored by Picmonic. In 2011, two medical students came up with the ingenious idea to combine medical education with unforgettable characters and ridiculously memorable stories. Featuring over 35,000 high-yield facts and graphics, Picmonic has helped over 600,000 students improve exam scores and perform better clinically. Picmonic has resources for pre-med and medical students, as well as other healthcare professions. Check out the show notes for a link to their website. Mention the podcast when you subscribe. With Picmonic, you can study less, but remember more.
One of the key issues that comes up with this patient population is a patient's religious freedom and autonomy to refuse a treatment. And this autonomy conflicts with our commitment as physicians to provide beneficial care while avoiding harm. I want to stop and talk briefly about this concept of religious freedom. And, why does our society put so much faith in religion? Pun intended, faith in religion. I'm a practicing Christian, but suppose a patient is faithless. Using their religious beliefs to support their autonomy sets a questionable precedent, at least in my mind. Suppose this patient doesn't subscribe to an accepted Western religion. Suppose the person is atheist or agnostic. Do they then have less autonomy because their medical decisions don't make sense and there's no religious backing to their decisions? I remember back in medical school and my psych rotation where we had a patient from the South Pacific and they were admitted inpatient psych and they kept talking about bula bula and these like kind of magical thinking was what the psychiatrist was kind of writing down and things weren't going well. I'm like, okay, this guy is getting worse and worse. But I went to undergrad with some Pacific Islanders. I think they were Tongan, and I knew that they practiced or believed in kind of a black magic or like a roots, and I think it was called bula bula. I'm pretty sure this is like years ago. And I was able to kind of explain this and like, okay, this is the quote unquote magical thinking. It's actually kind of part of their religion, part of their culture. So it's interesting to me when you start combining that religious freedom and putting that into the medical decision-making realm, how if it's a religion that we're not used to in the, in Western medicine, will we put less stock in their belief system? The important thing with these patients, like with any patient, is that we must still provide patient-centered, unbiased, informed consent. When we're consenting these patients and talking about the risk benefits of surgery, anesthesia, other medical procedures, and treatments, it's important to know, do those patients still actively practice the Jehovah's Witness faith? If they don't, do they still subscribe to some of those beliefs? If the patient changes their mind regarding acceptance of blood products, is this deviation secondary to a lack of decreased capacity due to their current illness? Are they, choosing to accept blood product now because they are anemic and altered and have an altered mental status, or they're septic and have an altered mental status? If this current acceptance of care is discongruous with their prior stated belief structure, is there a role for an advanced directive or for reaching out to a surrogate decision maker, for example? We know that the refusal of treatment is protected. So the First Amendment and the Constitution kind of guarees religious freedom if we're lumping this in with religion. In 1914, there was the landmark trial of Schlonendorf versus the Society of New York Hospital. This established the right of a competent adult to determine the course of his or her own medical treatment. And in 1990, the United States passed the Federal Patient Self-Determination Act, which required healthcare providers to inform patients regarding their right to determine the extent of care they receive and the right to have their decisions respected by healthcare personnel. We're going to jump into a couple of these issues in this episode of the podcast. We'll hopefully get some best practices of how we can provide the best care possible for this patient population. As we get started, one of the things that kind of annoys and bugs me, especially being at a center that takes care of a lot of Jehovah's Witness patients, is the colloquialization of their religion and referring to them as JWs. I see it in my mind as kind of similar to sicklers, in regards to patients with sickle cell disease. It takes a little longer to actually say out the whole thing, but when you start to shorten that, is it the back end of that losing a little bit of respect for that person, for their disease process, for their religious belief. So I always make it a point to refer to them as Jehovah's Witness patients. That's the religion that they choose to believe in. And so I do my best to respect it. Just grinds my gears when a little irksome when people are like, oh, JW this, JW that. I don't know how Jehovah's Witness patients feel about that, but that's just my own personal belief that I try to enforce or practice when I am working with these patients. Let's jump a little bit into the history of Jehovah's Witnesses. Back in 1870, there was a Bible study group in Pennsylvania. They believed in the literal interpretation of the Bible, except in cases in which it was obviously allegorical. Currently, there's a governing body of Jehovah's Witnesses located in New York. This is the global headquarters of Jehovah's Witness and has ultimate authority over all issues of doctrine. Now, a lot of this information I got from a couple of different journal articles. I did not kind of ping any actual Jehovah's Witness. I thought about bringing one on as a guest, but I kind of wanted to see what information I could find from my own, and just by doing kind of a literature review and looking online, because that is going to be the information that you're able to find in the middle of the night when you're looking this up, because you're presented with a Jehovah's Witness patient in extremis. So I wanted to see what had already been written, and I wanted to come into this a little bit naive so I could just kind of learn more as I went and then share that with you. So a lot of this information came from Current Opinions in Anesthesiology. It was the April 2014 edition, and a paper entitled Ethical Issues in the Care of Jehovah's Witnesses. There's a couple other papers, and if I remember at the time, I'll try to put them in the show notes. So again, back in 1870 is when the religion was formed. It wasn't actually until 1945 that a ban on blood transfusions was enacted. This ban was based on a couple of quotes found in the Bible, and some of those quotes are Genesis 9:3, "Only flesh with its life, with its blood, ye must not eat," end quote. Leviticus 17:10 through 16, "If any man of the house of Israel or any foreigner who is residing in your midst eats any sort of blood, I will certainly set my face against the one who is eating the blood, and I will cut him off from among his people. For the life of the flesh is in the blood, and I myself have given it on the altar for you to make atonement of yourself." Okay, more talk about blood. Then there's another verse, Acts 15:28 through 29. I feel like I should use like the Samuel L. Jackson voice from Pulp Fiction. In 1951, the Watchtower, which is kind of their, I guess, publication, there's an article that explained the reasoning that led to this ban on blood transfusions, that when sugar solutions are given intravenously, it is called intravenous feeding. Blood transfusion is feeding the patient blood, and the patient is, quote unquote, eating it through the patient's veins. Again, this was taken from that article in Current Opinions in Anesthesiology, and the author of that paper actually kind of corresponded with some of the elders of the Jehovah's Witness faith to get this information. Let's talk about some common misconceptions when it comes to this patient population. So it is a common misconception that if you give a Jehovah's Witness blood against his or her will, then they will be subject to eternal damnation. Another misconception is that if a Jehovah's Witness patient accepts blood, then he or she too would be subject to eternal damnation, right? So if you give it to them against their will, if they accept it, they're subject to eternal damnation with no chance for repentance. However, neither of these is true. This is again based on that paper from 2014, where this author actually emailed their lead office. A forced blood transfusion would not be viewed as a sin. Also, if under extreme pressure and while experiencing undue stress, a Jehovah's Witness was to compromise their belief and accept blood transfusions, in other words, if they caved in at a moment of spiritual weakness, yet still held to their beliefs, The individual would not be ostracized by the Jehovah's Witness community, whether kindness would be shown and pastoral help would be offered. Nevertheless, a blood transfusion or a compromise with one's conscience may leave the patient with deep emotional scars. So I definitely didn't know kind of that side of things, and wasn't sure that would that's how it would play out. I always heard, it's eternal damnation. In fact, since the year 2000, you are not disfellowshipped for accepting blood. You are considered to have voluntarily disassociated yourself from the church. This means that if you repent, you can remain within the fold. Over the years, there's been adaptations to keep up with advances in medicine, and they developed new guidelines regarding dialysis and cardiopulmonary bypass and acute normovolemic hemodilution and autologous blood donation. So normovolemic hemodilution is when you dilute somebody's blood before surgery, then you can draw off some of that blood and give it back to them later, which they can do for Jehovah's Witness patients. You just have to take a couple of other precautions. Essentially, the blood has to remain in circulation, so we're able to kind of rig up. We'll draw the blood off and leave it connected to the patient's IV in some format, and then you kind of have a little rocker or whatever to make sure the blood doesn't clot, but it is still in continuity with their body. A little timeline that this article actually included was in 1870, there's a study group that was formed. In 1879, they published the first issue of the Watchtower. It wasn't until 1901 that we discovered the ABO blood groups. In 1931, they changed their name to Jehovah's Witness. And the first hospital blood bank in the U.S. was in 1937. In 1945 was when they banned transfusions. 1961, the role of platelet concentrates was defined. In 1961, it also became a disfellowshipping offense to receive the blood products. And in 2000, they changed to a disassociating offense. As of 2013, there are approximately 7.9 million members worldwide and 1.2 million members in the United States. With regards to Jehovah's Witness belief system, although these verses, as stated previously, are not stated in medical terms, the Jehovah's Witness believers view these as ruling out transfusion of whole blood, packed red blood cells, plasma, as well as white blood cells, and platelet administration. However, their religious understanding does not absolutely prohibit the use of components such as albumin, immunoglobulins, and hemophiliac preparations. Each Jehovah's Witness must decide individually if he or she can accept these. The question always comes up, what happens with minors? So, life-saving transfusions can be given against parental wishes. Acknowledging is important, right? In real time for, treating a patient or a child of a Jehovah's Witness, which I have done, you don't want to just say, hey, yeah, I can transfuse your kid if I need to. No, it's more of a conversation. Yeah, I'll do everything I can to respect your wishes. But, for the health and safety of the child, if there's going to require a transfusion, then I am obligated to provide the best practice for the kid. And, depending on the surgery, if it's somebody taking off, if it's a frenulectomy or whatever, something minor, a skin tag, well, it's probably not going to come up. But if it's something that's more in depth, then that's probably going to be a bit of an awkward conversation. But that's just the way it is. A lot of this is professionalism and communication skills and how you're able to navigate these challenging discussions. For moral reasons that oftentimes go beyond the issue of the risk of a transfusion, Jehovah's Witness parents often ask that therapies be used that are not religiously prohibited. And this is in accordance with our medical tenet of treating the whole person. We want to try to observe the wishes of the family members. If I needed to transfuse a minor, I would do it without hesitation. There's kind of a whole process that you can go through with the court system to obtain a court order and all this other stuff. And I feel like if the transfusion was that necessary and that acute, then, you would have already transfused. But there is that when it comes to other issues like organ transplantation. So according to the Watchtower Society, which is a legal corporation for religion, Jehovah's Witnesses do not encourage organ donation, but believe it is a matter best left to an individual's conscience. All organs and tissues, however, must be completely drained of blood before transplantation. Again, they believe once that blood has been removed from the body, it should be disposed of, so they don't typically accept autotransfusion of pre-deposited blood. Many Jehovah's Witnesses do permit the use of dialysis and heart-lung equipment. These systems are in continuous flow with the patient. There's also a way to do kind of a cell saver where you're sucking blood off the surgical field and saving it, but keeping that in line with the patient as well. I've done a couple cases like that back in residency. What about medical liability? We really shouldn't worry about that because one, you're providing a thorough, informed consent, discussing the risk and the benefits. Number two, there's typically there's paperwork and documentation that you can provide. The informed consent is a process and a conversation. It's not really a legally binding anything. It's not really meant to protect you in the court of law. However, what you document from your conversation is what's going to protect you. But no, you really shouldn't be worried about liability when it comes to these patients, especially when you've been clear that, or they've made it clear that they would rather die than receive blood transfusion. Okay, well, they made it pretty clear. When it comes to Jehovah's Witness patients and surgery, so back in 1977, Ott and Collier, two surgeons out of Texas, I believe, they reported on 542 cardiac surgeries performed on Jehovah's Witnesses without transfusing blood, and concluded that this procedure...
Hey there, I hope you're enjoying listening to the show. I wanted to take a minute to talk about TrueLearn and thank them for sponsoring the Black Doctors Podcast. TrueLearn is a medical exam preparation company that helps you outperform on your boards. If you are a medical student or resident physician, you should definitely check out their products. If you sign up, please use the code BDPodcast and you'll get a discount. They have resources for both DO students as well as MD students and even physician assistants. When it comes to residency licensure, they offer question banks for over 8 different specialties. TrueLearn gives analytics that give you insight into your study habits, your question responses, and tracks you along with your peers. Students and residents average 20% improvements after completing a TrueLearn Smart Bank. Check them out at truelearn.com. And again, remember to use the code BDPodcast to receive your special discount. Now back to the show.
Cardiac surgeries performed on Jehovah's Witnesses without transfusing blood concluded that these procedures can be done with an acceptably low risk. They said the risk of surgery in patients of the Jehovah's Witness group has not been substantially higher than for others. Dr. DeBakey, the great world-renowned Dr. DeBakey, communicated that in the great majority of situations involving these patients, the risk of operation without the use of blood transfusion is no greater than in those patients on whom we use blood transfusion. These surgeons kind of added that the surgeon needs to establish a philosophy of respect for a patient's right to refuse a blood transfusion, but still perform surgical procedures in a manner that allows safety to the patient. Rather than considering these patients a problem, more and more physicians are beginning to accept the situation as a medical challenge. In meeting this challenge, they have developed a number of standard practices for this patient population, and this has been accepted at numerous medical institutions around the country. These physicians are at the same time providing care that is best for the patient's total good. So one of the surgeons wrote, "Who would benefit if the patient's corporal malady is cured, right? Their disease process is cured, but the spiritual life with God as he sees it is compromised, which leads to a life that is meaningless and perhaps worse than death itself." So we do owe it to these patients to basically do the best we can with their given constraints. See it as a challenge. One study from the Journal of Heart and Lung Transplant is entitled "Jehovah's Witness Patients Going the Extra Mile for Bloodless LVAD Implantation." And LVAD is a left ventricular assist device. Basically, it's a motor that takes over for the left ventricle of the heart. And what they found in that study was that it was actually published from some folks at the University of Chicago. They found that Jehovah's Witness patients currently face barriers in the availability, appropriateness, preference, and timeliness of access to care. Jehovah's Witness patients face unnecessary barriers in access to care, but they can be successfully operated on with the use of optimization protocols and open communication between the patient and care team. People talk about the ethics, however, of Jehovah's Witness transplants. It took me a while to wrap my head around it because, again, it doesn't make sense. This patient is not going to accept blood product. Why should they receive an organ, a heart, a liver, a kidney transplant if they're not going to accept blood? Personally, I still think it's a bit discongruous, but if their faith permits them to receive an organ, who am I to say that that's inappropriate? I would then defer to the organ transplant networks and the transplant surgeons and their team. They have a whole infrastructure in place to ensure that candidates have the best outcome as possible. So again, I defer to their judgment. And obviously, there's plenty of centers that are doing Jehovah's Witness transplants. So the ethics thereof, are basically, it boils down to two or a couple of ethical concepts and considerations. Should we not transplant Jehovah's Witness patients because the allocation of organs is difficult? It's a limited resource, and this will cost lives of other people who are not Jehovah's Witness who could have received these organs. Some would argue that these resources should be allocated to patients who will comply with the standard of care. However, if we look at the back end of this, the outcomes data of Jehovah's Witness patients receiving transplants does not show a significant difference. Without any data or significant data to show that these precious resources are being risked due to quote unquote non-compliance or patient refusal of blood products, it is not quite ethical to refuse to include Jehovah's Witness patients on a waiting list for an organ. So basically, if a Jehovah's Witness, it's a heart transplant and does just as well without receiving any blood products, than the next guy, then why not? And then a lot of surgeons will draw the line at maybe a redo heart transplant or a redo at some point. If we know the patient's going to need blood, or they know the patient's going to need blood to survive, then it doesn't really make sense to do this surgery. What are some of the best practices for caring for Jehovah's Witness patients? When treating these patients, we want to remember that principle of respect for autonomy. It's not the only principle that we need to observe. We need to observe the principle of beneficence, right? We want to do good for all, even for patients with belief systems that we don't entirely agree with. We want to do no harm. And sometimes we need to ensure that justice is being provided and patients are being treated fairly. The ethical treatment of these patients include not only respecting their autonomy, but ensuring that they understand all of their options. We need to explain their options for, blood products, blood substitutes, what's available at the institution. Can we do cell saver and keep that in circulation with the patient's blood? Can we do hemodilution and autologous donation, while keeping that in circulation with the patient? Can we manage them post-operatively? Maybe we don't get labs as frequently. Maybe we use small pediatric tubes to send their lab work done. One of the big things that we need to ensure we're doing is protecting this patient's privacy, especially if they do elect to receive blood. And we need to honestly evaluate our own ability to treat these patients, given the constraint that blood refusal may put on yourself as the physician or care provider and the healthcare system. Is your hospital best equipped and set up to provide care to this patient? Do you have any moral opposition to not transfusing and allowing a patient to die in front of you? I've had some attendees I've worked with before, or some partners, and it's important to kind of get these patients away from other family members, and then readdress this informed consent, not in a coercive fashion, but hey, just between us, this is our little secret patient physician privileged relationship. Do you really not want to receive a blood transfusion at the risk of death? And then just seeing what the patient says when they're alone and can be completely honest, and ensure that their privacy and their choices will be discretion will be used, and the information will not be shared. As physicians, and from an ethical perspective, we need to demonstrate our respect for the autonomy of competent patients by accepting their informed decisions, even when they refuse recommended treatments. It seems self-evident that without respect for informed refusal, the concept of informed consent is invalidated. Consent would then merely be acquiescence of the patient to the physician's recommendations. In order to give a true informed consent, a patient must have appropriate decision-making capacity. They must be able to understand the nature of the procedure, the risk, benefits, and alternatives, including that of doing nothing, and the probable outcome of both acceptances and refusal of the proposed procedure. In addition, the decision must be made free of coercion, and the coercion is present if the patient feels threatened, bullied, or subjected to irresistible pressure to make a decision that they would not otherwise make. A couple other issues that come up. So what is the role of a surrogate decision maker with these patients? So all Jehovah's Witness patients are encouraged to create and carry a durable power of attorney, explains in detail what their beliefs are concerning blood and blood products. Obviously, these are oftentimes lacking a lot of the data that we would need, especially in times of emergency. So we'll typically, and when in doubt, we kind of revert to reasonable patient standard. I think that's pretty fair if it's not explicitly written out, and if there's not a surrogate decision maker that is easily found that can reaffirm the patient's desires. Depending on what you need to do, you do want to loop in hospital legal affairs if there's any confusion, or the organization's ethics committee may be helpful. And then there's local Jehovah's Witness hospital liaisons in some communities that are available, and www.jw.org is also a resource. Oftentimes, these patients have expressed their intentions, but while under anesthesia, the need for blood becomes more critical. So in this case, it's important to recognize the principle of substituted judgment, which says that surrogates are to make the same decision that a patient would make if they were unable to do so. Once the patient's wishes are known, whether physicians agree or not, those decisions should stand unless there's some new information that becomes available. It's inappropriate to continue to badger the surrogate to change that decision to one that is more palatable for the physicians and healthcare providers. What is the physician's obligation? Because I am a strict proponent of autonomy for patients, but I am just as supportive of the autonomy of physicians. Every physician has the autonomy to say, I do not do this. So I'm an avid supporter of autonomy for both physicians as well as the patients that we take care of. So when it comes to physician obligation, the American Society of Anesthesiologists at least has developed guidelines for the anesthesia care of patients with do not resuscitate orders or other directives that limit treatment. This would fall under that, right? You can't give blood products. These guidelines kind of state that in a non-emergent situation, anesthesiologists have the right to excuse themselves from a patient's care non-judgmentally, as long as they're willing to refer the patient to another physician or healthcare provider in a timely fashion. This referral could even be to another medical center that has developed expertise in caring for Jehovah's Witness patients. If the situation is truly a life or death emergency with no time for a referral, then the anesthesiologist is obligated to care for the patient, trying as much as possible to adhere to the patient's wishes. However, if the anesthesiologist is concerned that he or she will not be able to comply with the patient's wishes, then the patient or surrogate should be so informed. In non-emergent situations, you are entitled to be a conscientious observer if you can find a replacement. If there are doubts about your obligations to the patient or to the child of a Jehovah's Witness, your hospital's ethics committee and or legal department should be consulted. This brings the concept of, I believe it's called sin boldly. So that's totally fine, right? Because if your moral code and structure will not permit you to allow someone to die on the operating room table, just say it is what it is. Ideally, you can have a partner or somebody that will be able to fulfill those wishes, take over and provide that anesthetic, provide that medical care, whatever it is. I've had talks with colleagues, and it's kind of been, I didn't do any poll or anything, but just in talks, like personally, if a patient did not want to receive blood transfusions and would rather die on the operating room table, I have got no problem allowing that to happen. If that's their wishes, I fully support patient autonomy. I would try to discuss this with a patient in private and talk to them. Hey, are you sure about this? Cool. All right. Is what it is. I've had partners that adamantly refused and would be like, yeah, if they're going to die without blood, I'm going to give them blood. So, at the end of the day, you have to do whatever that will let you sleep at night, and that you can know forever that you made the right decision based upon your own moral code. In one of the situations, I'll close with this anecdote, and I'll change some information for patient safety, for patient privacy. At some point in my career, I was providing care for a Jehovah's Witness patient who had a very complicated pregnancy requiring an operative delivery. And I remember, they, of course, came in the middle of the night, and we're scrambling. We're trying to get cell saver in place. We could, rig this up so we can continue to save some of their blood. One of the goofs, I remember trying to get a large bore IV in because they, in case they needed blood, because that's what we always did for these types of cases. And in retrospect, I'm like, well, we weren't going to give any blood anyways, but I guess we never know that anyways. I took a large bore IV, a 14 gauge IV, and I get this IV in. The patient sitting there, their significant other sitting there. and somehow like my hands were full and tied up, and I couldn't hold the right pressure over this 14 gauge catheter. And when I let go, like blood just like gushed down this patient's arm. I'm like, oh my God, all this precious blood that we can't get back. And everybody was just like, me, the patient's significant other, just staring at this like geyser of blood. Anyways, we get that all sorted, take the patient back for their procedure. It was done under a neuraxial anesthetic. So the patient was actually awake during the surgery, and things are going. And then boom, hemorrhage happens. Patient's bleeding out. Blood pressure's low. They're hypotensive. Blood pressure is, 60 over whatever. And, before we went back, one of the partners was like, had this whole come to Jesus, or I guess come to Jehovah moment. Had him sitting there like, hey, if we don't give you blood, you would rather die. And the patient's like, yeah. And then it's like, are you sure? Yeah. Are you sure? I'm like, whoa, like this is kind of getting a little coercive in my opinion, but I wasn't quite the attending a record. So I just, could only do so much. So a patient, refused it multiple times. Surgery's going on, hemorrhage. The patient needs blood and the patient's awake, right? Because it's under a neuraxial, and the patient's sitting there like, nope, I don't want blood. And my partner was like, if you don't get blood, you're going to die. The patient's like, nope, I don't want it. As now this patient's starting to like kind of fade in and out of consciousness. So then my partner goes and grabs a significant other, brings him to the room. And it was kind of one of those wild scenarios that happens in the operating room, because before the significant other was in like, the blue gown, and call them blueberries, whatever they were scrubbed out for the OR. Well, this time it's a little emergent. And so the person's just standing there in like street clothes with a bouffant cap on their head. And this person looks at their significant other that's laying there on the table, awake and hemorrhaging. And my partner was like, tell them they need blood. Tell us it's okay to give them blood. I'm like, whoa, this is kind of wild. And as this person stares at their significant other laying there on the operating room table, they point at them and like, they don't want blood. And the patient looks up, was like, yeah, I'm telling you, I don't want blood. And for me, that totally changed the way that I looked at Jehovah's Witness patients, because, my faith is not that strong. I would rather die than, receive a blood transfusion, or, substitute that for whatever it is. So in summary, I mean, these are patients with a belief system that we may or may not agree with. This isn't really different from any other patient that has a belief system that we may or may not agree with. And we should treat them as such with the utmost respect. Take time to talk with them, figure out what blood products they do or do not take, learn, what resources are available in your local area, and how we can best provide care for this vulnerable patient population. What are your thoughts? What are your experiences? Have you ever taken care of a Jehovah's Witness patient? How do you feel about the JW versus Jehovah's Witness, in reference to these patients? And just what are your thoughts? What other ethical issues, dilemmas, situations would you like me to discuss on the show? Thanks for listening to this week's episode of the Black Doctors Podcast. We're here because representation matters. We're getting towards the end of 2022 and the end of season 6 of the Black Doctors Podcast. We're at over 160 different episodes. You can go back and check out a lot of our older stuff, and we'll start to kind of recycle and shuffle back some of the classics and hits from days past. As we move forward into season 7, which we plan to launch in January 2023, if you are interested in sponsoring the Black Doctors Podcast, if you want to support the work that we're doing to increase diversity in the healthcare workforce, drop us a line. You can visit our website, www.theblackdoctorspodcast.com, or StephenBradleyMD.com. That's my website. You can leave a comment on the podcast. You can leave a message on social media. It's the same handles on Instagram, Black Doctors Podcast and Stephen Bradley MD. Shoot us a message. Love to hear from you. Leave a review, follow the show, like, share, all that good stuff. But if you want to sponsor us, get your name, get your business, get your product in front of our listeners. We have over 1,200 weekly listeners, weekly downloads, and we'd love to share that audience with you. And again, we'd love to have your support. So Reach out if it's something that interests you, and otherwise tune in next week to another episode of the Black Daughters Podcast, because representation matters.